The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this episode of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and thanks to everyone for listening in. Today, we will again talk about the budget reconciliation bill and its impact on the healthcare system. In podcasts earlier, I've given all of you some updates along the way on the progress in the House and the Senate and the political divide and contention along the way. Most recently, I told you how I thought smarter healthcare cuts aimed at price reform would be warranted, but that both parties lack the political will to do so. Well, the months-long saga is over. For good or bad, the budget reconciliation bill, known as the One Big Beautiful Bill, has passed. So in this episode of the Healthcare Labyrinth Podcast, I'm going to give you a final analysis of the bill, the political victory, the many provisions, the amount of cuts to healthcare, the impact on providers, and the impact on the uninsured rate. I will close out toward the end on how I see all these cuts playing out in the various healthcare lines of business. We will take 4 breaks today to divide up what will be a very long podcast. So let's get into it with a brief overview before our first break. The bill marks a tremendous political achievement for President Donald Trump and Republican lawmakers. President Donald Trump signed the BBB and touted it as a landmark major tax and domestic policy bill. The bill extends tax reductions ready to expire and enacts new ones. At the same time, it institutes massive cuts to Medicaid and the Affordable Care Act that could remove millions of people from Medicaid and the exchanges. The bill will mean tremendous changes for healthcare in America. As I noted, I have advocated for what I call smart healthcare reductions, ones that seek to reduce price in the system and promote greater efficiency. But the healthcare cuts in the bill are anything but that. While the GOP did not foolishly attempt to repeal the Affordable Care Act as they did in 2017, the stealthy reductions in the BBB will take us back in time before the 2010 passage of the ACA to much higher uninsured and underinsured rates. The uninsured rates will not be as high as back then, but the result is most assuredly a step back from affordable universal coverage. And the bill will complicate the problem of the underinsured. Combined, the uninsured and underinsured count at about 25% of the U.S. population. The roughly 85 million uninsured and underinsured will now grow again. Before we dive into the final healthcare reductions in the bill, I want to state one thing. I do not oppose every healthcare provision in this bill. I will point out below that some elements of the bill done right would have been acceptable to me. They touch on my argument for smart healthcare cuts. Without a doubt, some of our government programs have grown way too much and actually threaten the very existence of government programs and healthcare coverage more broadly. With that, let's take our first break, and when we come back, we will get into the political backdrop of the bill and what admittedly appears to be a major victory for the president, whatever I think of the healthcare cuts in the bill themselves. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back to the Healthcare Labyrinth Podcast. We are talking about the final passage of the One Big Beautiful Bill and what it means to healthcare. We wanted to discuss next the political backdrop of the bill. After the 2024 election concluded, it was clear that President Trump and the Republicans would have a tough time cobbling together enough votes in each house to pass a reconciliation bill with all the commitments made during the campaign. The House and Senate each had very narrow majorities, meaning just a few votes in either chamber could sink the mega bill. What's more, the Senate essentially requires a 60-vote supermajority for bills to pass. The only exception is to use the budget reconciliation process, allowed once for each year's budget package. But the reconciliation process has strict rules related to what can and cannot be put in the bill. These are known as the Byrd rules. The votes in each chamber and again in the House were extremely tight, but the GOP caucus successfully navigated the intricacies of the budget reconciliation process, as well as ameliorated the concerns of both sides of the GOP caucuses to pass the bill. The House GOP has a few dozen moderates from blue or bluish states, as well as the rightist House Freedom Caucus. The Senate has roughly a half dozen moderates or pragmatic conservatives. The bill was months in the making, and Donald Trump is being given considerable credit for its passage. Whatever you think of the bill itself, its passage can be described as a political masterstroke, given the tight vote count for the GOP in each chamber. Trump stayed engaged with lawmakers on each vote, the initial House draft, the Senate recrafted one, and the House adoption of the Senate version. He is credited with creating a full-course press to pass the bill, including a mixture of cajoling, education, and even political threats. Trump, Vice President J.D. Vance, Centers for Medicare and Medicaid Services Administrator Dr. Mehmet Oz, Treasury Secretary Scott Bessent, other cabinet officials, Speaker Mike Johnson, Senate Majority Leader John Thune, and other GOP leaders in each house all executed on final passage over several months. Let's next talk about how these were stealth attacks on healthcare versus a full frontal assault. Throughout the saga of the budget bill, I have made the case that the GOP was in stealth attack mode this time around. What I mean by that is they learned a bit from their frontal assault on the ACA in 2017. At that time, they attempted to repeal the Medicaid expansion and the exchanges. While the bill went down to defeat, the Democrats capitalized on the failed effort to take back control of the House during the 2018 elections. For the 2026 election, the Republicans will attempt to convince the nation that the stealth reductions in the BBB to Medicaid and the exchanges should not lead to massive impacts and are rooted in good government by attacking waste and abuse and ensuring only those who meet requirements obtain coverage. As you will see below, I don't agree with the argument, even though I am a Republican. The party in power at the White House tends to historically lose seats at a midterm election. With the tight House count, the likelihood was always that the Democrats would win back the lower chamber. The Senate looks still likely to be Republican after the 26 elections. But will the stealth cuts in 2025 play the same way as the frontal assault from 2017 and swing the House in a major way in the 26 elections? Only time will tell. Many of the major reductions to health care will have yet to have major impact until after the 26 vote. But the disorganized Democrats promised to make the bill a huge campaign issue. So historic trends and the stealth cuts in the Budget Reduction Act could indeed swing the House back to Democrats after the 26 election. With that, let's take our second break, and when we come back, we will get into the final healthcare reductions in the bill. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back to the Healthcare Labyrinth Podcast. We are talking about the final passage of the One Big Beautiful Bill and what it means to healthcare. We are going to get into the healthcare reductions now. Tracing the many healthcare reductions over the past few months is not easy. Changes were made in the House before it first passed the bill. The Senate then made its mark on the bill with various iterations and changes. I have combed numerous sources for the inventory I'm going to outline, including the bill itself and summaries. I would strongly recommend Healthcare Policy Group KFF's analysis of the final bill, as well as the Hill's ongoing coverage. These can be found at the link at the end of a blog I wrote on the passage of the Big Beautiful Bill on July 7th at the blog tab of healthcarelabyrinth.com. I have broken out the reductions by program area as KFF does. So this analysis that I'm talking about here again is based primarily from the KFF briefer I just talked about. So let's get into the major reductions. And again, we'll break these out. The first area is Medicaid. And I'm just going to quickly list these things. There's many of them, but I haven't really edited them too much because you really have to know what is in this very mammoth bill. So the first Medicaid provision would eliminate what's known as the temporary incentive for states that newly adopt expansion. This is effective January 1, 2026. So no new states could come in and get this 100% reimbursement from the start. Number two, another provision requires states to impose cost sharing of up to $35 per service on expansion adults with incomes between 100 and 138% of poverty, with some services excluded. Cost sharing for prescription drugs are limited to nominal amounts, and it overall maintains the 5% of family income cap on out-of-pocket costs. This is effective January 1, 2028. The next provision limits federal matching payments for emergency Medicaid for individuals who would otherwise be eligible for expansion coverage, except for their immigration status. The limitation is to reimbursement for the state's regular state matching rate. This is effective January 1st, 2026. The next provision requires states to condition Medicaid eligibility for individuals aged 19 to 64 applying for coverage or enrolled through the ACA expansion group or a waiver on working or participating in qualifying activities for at least 80 hours per month. So this is known as the work requirement provision. Certain exemptions apply. Those denied Medicaid coverage would also be not denied subsidized exchange coverage. This is effective not later than December 31st, 2026, with the ability of states to enact them earlier. Extensions can be granted to states showing good faith until December 31st, 2028. The next provision requires states to conduct eligibility redeterminations at least every 6 months for Medicaid expansion adults. This is effective for renewals scheduled on or after December 31st, 2026. The next provision requires states to obtain enrollee address information using reliable data sources, and that the federal government establish a system to share information with states. The federal and state governments are required to share information. They have various effective dates for this provision. The next provision delays implementation to 2034 of various parameters of two Biden-era rules meant to reduce barriers to and streamline enrollment in Medicaid. The next provision restricts the definition of qualified immigrants for purposes of Medicaid enrollment. This is effective January 1, 2026. The next provision limits retroactive coverage to 1 month prior to application for coverage for expansion enrollees and 2 months prior to application for coverage for traditional enrollees. This is effective January 1, 2027. The next provision prohibits states from establishing any new provider taxes or from increasing the rates of existing taxes. It also tightens the conditions under which states may receive a waiver of the requirement that taxes be broad-based and uniform, such that some currently permissible taxes, such as those on managed care plans, will not be permissible in future years. These provisions are effective on passage, with states having at most 3 fiscal years to transition existing arrangements that are no longer permissible. The next provision also applies to provider taxes. It reduces the safe harbor limit for provider taxes for states that have adopted the ACA expansion by 0.5% annually starting in fiscal year 2028 until the safe harbor drops from the present 6% tax rate and reaches 3.5% in fiscal year 2032. The new limit applies to taxes on all providers except nursing facilities and what are known as intermediate care facilities. It also applies to local government taxes in expansion states. The next provision says that upon passage, HHS is directed to revise state-directed payment regulations to cap the total payment rate for inpatient hospital and nursing facility services at 100% of the total published Medicare payment rate for states that have adopted the Medicaid expansion and at 110% of the total published Medicare payment rates for states that have not adopted the expansion. Existing approved state-directed payments are reduced by 10 percentage points each year, beginning January 1, 2028, until they reach the allowable Medicare-related payment limit. States that newly adopt the expansion after enactment have a cap of 100% of the Medicare payment rate, and that applies at the time coverage is implemented even for payments that had prior approval. The next provision requires that HHS certify that 1115 demonstration waivers are not expected to result in an increase in expenditures compared to expenditures without the waiver, and to specify a methodology for applying any budget neutrality savings in a waiver extension period. This is effective January 1, 2027. The next provision requires HHS to reduce federal financial participation to states for identified improper payment errors related to payments made for ineligible individuals and overpayments made for eligible individuals. This is effective January 1st, 2030. The next one prohibits HHS from implementing, administering, or enforcing the nursing home rules minimum staffing levels passed under the Biden administration until October 1, 2034. The next provision reduces the maximum home equity limits to $1 million, regardless of inflation. That is for Medicaid eligibility. This is effective January 1, 2028. The next provision says that as of January 1, 2028, it allows states to establish 1915C home and community-based service waivers for people who do not need an institutional level of care. The next provision establishes a rural health transformation program that will provide $50 billion in grants to states between fiscal years 2026 and 2030, which are to be used for payments to rural healthcare providers and other purposes. And next, the last provision requires states to conduct checks at enrollment, re-enrollment, and on a monthly basis to determine whether HHS has terminated a provider or supplier from Medicare or another state has terminated a provider or supplier from participating in Medicaid or the Children's Health Insurance Program. This is effective January 1st, 2028. With Medicaid reductions covered, let's take our third break, and when we come back, we will get into other healthcare reductions in the bill. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back to the Healthcare Labyrinth Podcast. We are talking about the final passage of the One Big Beautiful Bill and what it means to healthcare. We're going through healthcare reductions, and now we will cover the Affordable Care Act exchange cuts. Well, the first provision here bars any consumer who enrolls in a plan via a special enrollment period that is not a qualifying life event from receiving premium tax credits and cost-sharing reduction subsidies. This is effective for 26 plan years and later. The next provision on the exchanges effectively means the end of auto renewals by requiring pre-enrollment verification of eligibility, including household income, whether someone is an eligible alien, healthcare coverage status, place of residence, family size, and any other information deemed appropriate by HHS. This is effective for tax years beginning after December 31st, 2027. Consumers can still enroll in a plan but cannot receive premium tax credits or cost-sharing reductions until after they verify their eligibility. The next provision requires that all premium tax credit recipients repay the full amount of any excess, no matter their income, at tax time. This is effective for tax years beginning after December 31st, 2025. The next provision limits eligibility for subsidized ACA exchange coverage to lawfully present immigrants who are lawful permanent residents, compact of free association migrants residing in the U.S., as well as certain Cuban and Haitian entrants. This eliminates eligibility for other lawfully present categories. The next provision eliminates subsidized exchange coverage eligibility for all lawfully present immigrants with incomes under 100% of the FPL beginning January 1, 2026. And the last provision for the exchanges treats individual market bronze and catastrophic plans as a high deductible health plan that can be paired with a health savings account. This is effective January 1, 2026. Let's move on to some Medicare reductions. So the first provision in Medicare restricts Medicare eligibility to U.S. citizens, green card holders, certain immigrants from Cuba and Haiti, and people residing under the compacts of free association. Thus, the bill eliminates Medicare eligibility for people not including in those groups, such as those here with temporary protected status and refugees and asylees. It terminates Medicare benefits no later than 18 months from enactment of the legislation for anyone who is currently receiving benefits but would no longer be eligible under these changes. The next provision delays until October 1, 2034, most provisions of a September 2023 CMS final rule that was meant to reduce barriers to enrollment for Medicare beneficiaries in what are known as Medicare savings programs. Next, the bill provides a temporary one-year increase of 2.5% to the Medicare physician fee schedule conversion factor for all services furnished between January 1, 26 and January 1, 27. And next, Another provision modifies the orphan drug exclusion in the Inflation Reduction Act's Medicare drug negotiation provisions to include drugs designated for one or more rare diseases or conditions, and where the only approved indication or indications are for one or more rare diseases or conditions. The period of time that the drugs are on the market with only one or more orphan indications shall not count toward the 7 or 11-year time frame that determines eligibility for selection. So in effect, this extends the time frame that these orphan-type drugs are protected against drug price negotiation. This is effective for drugs selected for negotiation beginning in 2026. The next provision prohibits HHS from implementing, administering, or enforcing the nursing home rules minimum staffing levels until October 1, 2034. And as we conclude Medicare changes, it's important to remember that because the budget deficit increases under the reconciliation bill, the so-called pay-go sequestration of spending could occur and impact Medicare unless overridden by a future Congress. Under the rules in law, Medicare can be cut by up to 4% in a given year. Based on an earlier version of the bill, the Congressional Budget Office estimated that a $45 billion cut to Medicare could occur in 2026, and these cuts could total at least $500 billion over the 2026 to 2034 budget horizon. Let's move on to some of the BBB's changes to health savings accounts and a few other reforms. Well, the first provision treats individual market bronze and catastrophic plans as high-deductible health plans that can be paired with a health savings account. This is effective January 1, 2026. The next provision provides that certain direct primary care offerings will not be considered health plans, allowing individuals covered by these arrangements to be eligible for an HSA. This will only apply if the fixed periodic fees for the DPC offering do not exceed $150 monthly or $300 monthly where more than one individual is covered. DPCs not considered health plans are limited to those offering primary care services and do not include services that require general anesthesia, prescription drugs, except vaccines, and laboratory services not typically administered in an ambulatory primary care setting. This provision is effective January 1st, 2026. The next provision permanently allows high-deductible health plans to cover telehealth and other remote services before the deductible and still qualify as an HSA-eligible high-deductible health plan. If an individual has other coverage for telehealth and other remote care services while participating in an HDHP, they will still be eligible for HSA contributions. This is effective for plan years beginning after December 31st, 2024. With the cuts covered, let's take our last break, and when we come back, we'll sum this all up for you. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back to the Healthcare Labyrinth Podcast. We're talking about the final passage of the One Big Beautiful Bill and what it means to healthcare. So let's talk the bill's impact now. Medicaid and exchange reductions in healthcare would be over $1 trillion over a 10-year period. The 5 biggest reductions occur in the following areas. Mandating work requirements in Medicaid, $326 billion over 10 years. The Medicaid provider tax limitations and phase down, $191 billion over 10 years. Repealing the Biden administration's Medicaid streamlining rule, $167 billion over 10 years. Revising the payment limit for state-directed payments, $149 billion over 10 years. And increasing the frequency of eligibility redeterminations for the ACA expansion group in Medicaid, $63 billion over 10 years. In an analysis of the House version of the bill, the Urban Institute and the Robert Wood Johnson Foundation break down how providers, hospitals, physicians, and drugs are impacted in each state by the reductions to Medicaid and the exchanges. Over the next decade, the bill would decrease spending by $321 billion to hospitals, $81 billion to physicians, and $191 billion for drugs. Spending on other healthcare services would decline by $205 billion. These are all, again, over the decade period. If the exchange premium tax credits expire, spending would decline by an additional $262 billion over 10 years. Hospitals, an additional $103 billion cut over 10 years. Physicians, an additional $39 billion cut over 10 years. And drugs, an additional $50 billion cut over 10 years. Spending on other healthcare services would drop an additional $70 billion over 10 years. Republicans argue that no one truly eligible for these healthcare programs will be denied enrollment and that the bill is focused on fraud, waste, and abuse. But notwithstanding what Republicans say, millions will indeed lose coverage as a result of social barriers, red tape, administrative hurdles, the great inefficiency and lack of infrastructure at state Medicaid agencies, and lower availability of revenue in states to match federal dollars. The Senate version that was adopted by Congress increased estimates of coverage losses from $10.9 million under the House bill to $11.8 million in Medicaid and the exchanges under the final Senate-passed bill that was ultimately adopted by both houses. If we add the losses estimated from the expiration of the enhanced premium tax subsidies at the end of this year, $4.2 million, and the just finalized Trump administration rule tightening enrollment in the exchanges, an additional loss of $900,000, total losses, all told, could become about $16.9 million. So the uninsured ranks will go up by almost $17 million. Overall, the reductions clearly threaten to destabilize the health plan industry and coverage in general in a major way. The exchanges could see a return to bleeding enrollment, high risk, soaring premiums, exits by plans, leaner benefits, and less plan and provider access. Financially, health plans could see a troubling financial picture moving forward in the exchanges. We're already seeing this with some financial concerns raised by Centene, Molina, and others. Due to a loss of enrollment during the reintroduction of Medicaid redeterminations after the COVID pandemic, Medicaid is already reeling from rising risk and a mismatch between costs and rates. This could continue as losses occur under the budget bill. What's more, state revenue is already drying up due to the elimination of enhanced matches during COVID. The provider tax restrictions and phase down could mean further troubles funding managed care rates in the future. Medicare Advantage is financially troubled right now, as we know. Statutory pay-go sequestration, if that is triggered, could further undermine health plan recoveries in the industry. This could lead to further geographic and benefit contraction, higher premiums, and increased cost sharing. Commercial and employer coverage are seeing huge surges in utilization. Loss of provider revenue in government programs could lead providers to demand higher rates from the commercial sector. This could lead to employers further cutting back on benefits and transferring more cost onto employees in terms of premiums and cost sharing. Now, I told you I am not against everything the GOP put in the reconciliation bill. As a few examples, I am sympathetic to some limitations over time on provider taxes and state-directed payments. These do seem excessive in many states. Some limited cost sharing. This contributes toward the goal of personal responsibility. Some eligibility reform in Medicaid and the exchanges to root out fraud and improper enrollment. Reining in 1115 waivers and the scope of benefits. And also expanding the use of health savings accounts. But the budget reconciliation bill's passage will mean a huge fallout in healthcare. Instead of looking at so-called smart cuts to reform price and migrate to a more efficient system, Republicans again elected to target coverage as their solution to slowing the growth of healthcare. It's a penny-wise and pound-foolish approach. While the bill does not technically repeal the ACA, it does take away a great deal of the progress we have made on the coverage front since 2014. The GOP will take away more than a third of the coverage gains. That is disturbing. With that, we will conclude this edition of the Healthcare Labyrinth Podcast, and we will see you next week. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.